Okay, welcome. Thanks for viewing this short video. My name is Surabhi Kuke, and I will be sharing with you a little overview of the 2002 needs assessment conducted by the National Health Resource Center on Domestic Violence. I'll be sharing a little about our goals, our process, as well as findings and recommendations. So to begin, some of the broad assessment questions we had were to ask, what are domestic violence stakeholders? And this included healthcare providers, community providers, and advocates. What are their experiences with domestic violence training and technical assistance, specifically HRC resources? I will flip between calling it NHRCDV and HRC, but HRC is what we typically call it. We also wanted to know what barriers exist for domestic violence stakeholders in accessing and utilizing available training and technical assistance. What resources DV stakeholders believed would be most helpful in addressing that intersection between violence and health. And what path we should take at the HRC to develop and disseminate training and TA that fills the gaps that they perceived. And finally, to determine or learn what survivors think providers need to do better or differently to meet survivor needs in the healthcare setting. Based on these questions, we designed a needs assessment that included two parts. First, a survey that went to clinical and community health providers, as well as domestic and sexual violence advocates. And second was a series of virtual listening sessions with survivors in partnership with other resource centers and local organizations. We held 5 of these listening sessions, one in a general population of survivors that we recruited through our listservs and the networks through those listservs. Interestingly, this group was predominantly immigrant, but they were recruited as sort of general survivors without a specific demographic category. And then we focused in on our focus areas. In our grant, we have been thinking about survivors living with HIV, survivors who identify as Black birthing people, Native Indigenous survivors, and survivors. Well, we have other focus areas, but we decided to do one in Spanish. So we focused in on survivors who are more comfortable speaking in Spanish. So for these 4, we partnered with other organizations, namely Positively Safe at NNEDV, Genesee Center in Los Angeles, the National Indigenous Women's Resource Center, and Esperanza United. So the key findings from this survey, I'll just provide in a quick overview and then go into some of the findings more explicitly. The first is that providers still prefer in-person TTA the most, but are very pleased to access both live and asynchronous webinars. The most common barrier to participating in TTA provided by the HRC was, interestingly, cost, even though it is free. So it led us to ask some more questions about what they perceived the cost could be, trying to determine who thought cost was a barrier, if they were administrators or frontline workers. And we learned that it didn't matter. Even when we looked at who it was, everyone perceived cost to be a barrier. So there may have been some other calculus going on in the respondents' minds where they thought about cost in terms of time or, time that staff couldn't do other work or something like that. The majority of providers indicated awareness of the importance of supports that would address social determinants of health, including housing, financial assistance, job training, placement, legal advocacy, and supports for people who use harm or battering intervention programs. And providers broadly assess themselves as relatively unprepared to serve Black birthing people, Indigenous people, and other marginalized focused populations. So to get into the survey data a little bit, this is specifically about the respondents in English. Over half of them were domestic and sexual violence advocates, and about 20% were either healthcare delivery system, employed by a healthcare delivery system, or employed by a community-based organization. We divided them by employer so that it would facilitate different kinds of analysis for us. But community-based organizations were quite broad and could include healthcare providers, but specifically not a DVSA organization. So for providers working in a healthcare delivery system, we wanted to know which were the most useful things in their healthcare setting, of the free learning opportunities that we had. So namely, clinical guidelines, conferences, and by and large, like I mentioned earlier, webinars were the highest in terms of what people found most useful, followed by the clinical guidelines and conferences, clinical guidelines, workshops, and conferences. So some indication that what we are doing is aligned with what they find useful. When reflecting on barriers, respondents indicated cost, as I mentioned before, as well as time, that they cannot fit it into their workday. Some were concerned about continuing education credits. And it's hard to tell here in this table, but that they indicated they don't have control over their time, so they cannot freely participate in events, even if they wanted to. In community-based organizations, providers indicated some very similar things. By and large, they appreciated webinars the most, and workshop presentations, as well as training videos, the short video vignettes that we have on our YouTube channel that help providers kind of get a model for intervention in the clinical setting or in the social service setting. They, of course, also loved conferences and other community engagement events that we have hosted. So again, a little bit of affirmation for the kinds of activities we are doing. And for them, the barriers also were about cost and time. This led us to do some internal, reevaluation about how we communicate about cost and what kind of cost alleviation we might invent to kind of reach people without this, to alleviate this concern. And when asked what they're currently using to make referrals, well over half of them were referring directly to behavioral health supports, and followed by case management. And it was helpful to notice that both kinds of providers were very familiar with and understood the need and importance for addressing the social determinants of health, thinking about housing, childcare, helping people get access to financial assistance, emergency assistance, things like this, as well as safety planning and support groups. So our respondents had a very high awareness of these kinds of things, and I think it confirmed for us that we could go to kind of like the next level in our education with teaching about how to do this better, how to really respond and address the social determinants of health. So the key recommendations from the survey showed, as I mentioned, further inquiry into why trainings are perceived as cost prohibitive and how to alleviate that concern, improving our communication about free, accessible training resources and opportunities, creating funding opportunities for providers and advocates to be able to avail of trainings without losing work time, or simply one idea is to pay people to participate, build it into grants, encourage people to participate in continuing education with an incentive. we recognize that we need to update the business case for this kind of provider education to encourage organizational leadership to rethink allocation of staff and resources. I didn't show this data, but we understood that we need to keep and possibly expand accreditation for continuing education credits, or partner with an organization that can do this for us, and survey our stakeholders to identify which CEUs might be most important to offer. There was a lot of consensus that CEUs are worthwhile and they want them. And that we should continue our emphasis on partnership building between healthcare delivery systems and advocacy resources so that providers are aware of what is available and where is available. We learned that we need to build on providers' awareness of the impact of social determinants of health to expand to the layered impact on survivors. They are ready to go there. Sort of what I was mentioning earlier, that we can step up our training and TA to really address the how, not just the why. Continue building strong web-based resources with downloadable or printed resources that can be ordered. Even though these weren't the highest proportions, there were a substantial number of respondents that still printed out downloaded materials that we've developed. To develop TTA that addresses the unique needs of Black and Indigenous survivors, as well as our other focus populations. That is clearly essential. They identified that they needed more in that arena. Continue and expand TTA resources on trauma-informed care, supporting staff experiencing burnout, and how organizations can integrate these values in their models of care. And finally, to strengthen accessibility of trainings, including closed captioning, Spanish, and ASL interpretation where possible. So now to move to the findings and recommendations from our listening sessions. As I mentioned, we held 5 listening sessions, 4 in English, 1 in Spanish, and the discussion questions were the same, obviously, across all 4, and they were these 4 questions. What was your experience like with your healthcare provider if or when you disclosed experiencing violence? This could be with a doctor, nurse, advocate, doula, community health worker, etc. This could also take place in a variety of settings, such as your home, a friend or child's healthcare visit, a clinic, a hospital, etc. Number 2, would you have preferred the interaction to have gone differently than it did? How would you have actually wanted it to go? Number 3, did the providers share any resources with you, and were they helpful? What specifically did you find helpful about these resources? For instance, were they small or easily hidden? Were they easy to read, visually appealing? Were there any resources that would have been more helpful that the provider did not give you? And finally, number 4, the question was, overall, what do you wish your healthcare provider knew about survivor experiences so they can better meet survivor needs? These 4 questions gave us an opportunity to have discussions that ranged from 60 to 90 minutes. Some groups were smaller. They ranged in size from 5 to 12. And so the first finding is that providers did not offer survivor-centered trauma-informed services, including screening in response to intimate partner violence. One of the most resounding responses heard from survivors was the need for more training for health professionals on domestic violence. Survivors highlighted the importance of training to include a deeper understanding of what power and control are and the ways that different forms of abuse are perpetrated, so beyond physical and sexual violence, how to support survivors and what needs they may have after leaving an abusive situation, that getting them out is not the end of the story, how to screen patients for DV in a way that is trauma-informed, how to show empathy and validate survivors when they disclose abuse, the importance of confidentiality in maintaining trust and safety for survivors, and what trauma is and how it manifests in physiological ways. Finding 2, survivors feel that health systems are not designed to support their needs. Survivors spoke about the importance of health systems being more friendly to survivors. They spoke about the need to have more folks in health systems who are aware of domestic violence, such as social workers, and the need to have more domestic violence advocates integrated into health systems. Additionally, survivors spoke about the importance of health systems having partnerships with local community providers. WORM referrals can be especially useful for getting survivors connected to domestic violence experts. Finding 3 was that survivors from marginalized groups had faced additional challenges. Many survivors shared how providers lacked cultural competency to accurately care for them and help them navigate the abuse they experienced. This could be mitigated by creating more training on cultural humility in the short term, but also building out a more diverse workforce that has racial and language concordance in the long term. Survivor experiences as part of diverse communities highlighted the lack of partnership between healthcare providers and culturally specific organizations. Partnerships could be beneficial in creating more health and DV resources that take into account the specific needs of unique populations who may experience distrust of healthcare systems. This really elevated for us the importance of our collaboration with other resource networks, resource centers rather, culturally specific resource centers. And finding 4, connecting to DV organizations aided healing for survivors. This was lifted up over and over again. Survivors highlighted how impactful domestic violence programs can be in helping them understand, process, and heal from their abuse. They talked about the need for more advocates to be part of healthcare systems so they can be referred more easily and/or connect with DV programs while accessing healthcare. Survivors spoke about the importance of health systems having partnerships with local community providers. And again, WORM referrals are especially useful for getting them connected. So in conclusion, we determined that the findings of our needs assessment offer validation about the direction of the training and technical assistance that we provide in the National Health Resource Center on Domestic Violence. Providers expressed appreciation of the resources available and asked for more of the same. Insights of the survivors will be an important added element to improving the trainings and online resources that we have, both to help providers understand the importance of trauma-informed and healing-centered approaches and to inform the direction of new training and technical assistance development. Thanks so much for your time.